Now we call upon Dr. Mallikarjun sir, who will be speaking on challenges in managing those with all started since the time of surgery in post-operative patients.
Okay, to start with, I had an experience last around 15 days back. We have an emergency phone number in our hospital where the patient has any post-op emergency, they call. So one patient called and he told to our nurse that I have severe itching, something is going in my eye. I had to, so they gave an emergency appointment, and he was supposed to come to our OPD. I was thinking, well, what would have happened to the patient? Maybe somewhere I did a wrong surgery, or something happened to the IOL. But when a patient came and examined, he had a simple MGD. So that is the importance and critical thing about this dry eye or MGD after post-op cataract surgery. Dry eye, especially MGD, is the most common cause for itching and redness following cataract surgery. The symptoms may be very temporary, but they are very annoying to the patient and very annoying to the operating surgeon also. And the prevalence of dry eyes following cataract surgery varies between 10% to 57%. That was the studies have been shown. And they are more symptomatic after 3 to 4 weeks. They won't complain immediately after cataract surgery, but they complain after 3 to 4 weeks. Why it happens? So why it happens, especially after cataract surgery? Because we use a lot of medications. They contain all the preservatives like BAK, and they cause epithelial toxicity. And there would be a meibomian gland dysfunction. And in SICS, we do a conjunctival peritomy. This destroys the goblet cells and reduces the mucin secretion. This leads to the dry eye. And when you do a more corneal entry and a bigger corneal section, that denerves the corneal nerves, that would also cause a dry eye. And if there is a more exposure time to the microscope, that also leads to the dry eye. So we have to practice doing surgery a little bit faster. And one more important, which we don't give importance, is the lid speculum. The special applied on the lids by the speculum. So if you apply more and if you retract it more, and it will obliterate the structures of the meibomian glands. That can also lead to post-op MGD. Following cataract surgery, there will be more inflammatory cells, and that leads to meibomian gland dropouts and leads to meibomian gland dysfunction. And we also have found out that the dry eye is more common in MSICS, that is SICS, than phacoemulsification. This was a study done in our hospital, and most commonly seen in women because of their menopausal age or hormonal changes. And this can happen without pre-existing MGD. That we have to keep in mind, because pre-operatively we would have done all the investigations, correct examination, but still it can happen after cataract surgery. Other risk factors include diabetes mellitus, autoimmune disorders, and use of antihypertensive drugs, because nowadays most of the people are becoming hypertensive, and even in the age of 40s, 50s, they are on the antihypertensive. This also leads to dry eye. And antihistaminics, antidepressants, thyroid malfunction, and hormone repellent therapy, all these are the risk factors for the dry eye. This is all the science. But what actually patient thinks is, we have to deal with different minds and different patients, because what they think, the IOL is scratching in my eye, the IOL is tilted. This is all my experience I'm telling. And surgery has not been performed properly. My nerves have been cut. And these patients, I think, who are doing cataract surgery, they would have had this experience. And they keep on coming. They come on for 1 month and you give some drops, and again they come on 2 months. So we need to counsel them properly, and best thing is you have to examine them fully. Don't neglect them. Just do. We know this is something dry eye or something, and don't do a quick examination and give some drops and send them. You have to talk to them nicely, and you have to examine properly and do some investigations. Then tell them there is nothing wrong, and then they will be happy. And these subtle signs you can see in the slit lamp examination. There will be enlarged meibomian glands, something meibominuria, there's more secretion of the meibomian gland, and capping of the meibomian gland. These are all the indications of MGD. Whenever I see the patients, I know that the patient has some amount of dry eye. First thing I tell them, your IOL has been fixed perfectly. Before telling anything else, I tell them your IOL is correctly fixed. Then the 50% of their apprehensions will come down. Because they think is only because they would have paid for, especially you do a premium IOL, they would have paid for that money. They always think of this is something wrong with the IOL. Even it holds good for even uneducated or even some IAS officer, anybody. They always think in terms of intraocular lens. And some investigation you can do. There would be some less the tear film height would be less, and that you can grade them according to that. You can plan your treatment. And your routine OPD, you can do a Shermer's test and T-BUT. There we can differentiate between whether it's aqueous deficiency or evaporative dry eye. And fluorescent staining can will give in the interpupillary area. There will be staining, and rose Bengal staining also will give in interpupillary area because it stains on the devitalized cells, and you can see a stain on the conjunctiva as well. And in more symptomatic patients, you can use an autorefractor. Everybody has the autorefractor, and you take a picture and you can assess the meibomian glands. So sometimes you will see a good meibomian sign. Sometimes you see a good number of drop-offs of the meibomian glands. Based on that, you can assess, and also it will help us to manage the patient. Management is again counseling the patient and also giving tear drops. CMC works well in aqueous deficiency, and sodium hyaluronate works well in evaporative dry eye. And you can also give a Trialose. It causes deeper hydration, protects against oxidative insults. And in severe cases, you can add cyclosporine or tacrolimus. One more important thing I always tell the patient is lid hygiene and warm compresses and lid massage. This is a very simple technique and it works very well. And you have to give a very good instruction to them because they should know how to do it. So they have to apply this warm cotton on the lid at least for 2 minutes. They close the eyes, apply it for 2 minutes, and massage with the finger placing horizontally for the upper lid from up to down, and for the lower lid lower to down, because that's how the meibomian glands are situated. They are vertical. So when you apply pressure like this, whatever the secretions are accumulated, they would come out. So I always show this video to them and teach them, and it works well. And in severe cases, we can try a punctum plus. There are temporary punctum plugs like collagen material available, and permanent silicone type of punctum plugs are available that can also be used. And other most likely causes for dry eye is conjunctiva callosis, which we usually try to miss. It's a redundant conjunctiva, which usually seen below the lower limbus, and this carefully you have to examine. And treatment is very simple. You can add a tear drop if it is less symptomatic, and if they are very symptomatic, you can do a simple excision of the conjunctiva. You have to mark pre-operatively where is the callosis, and under topical anesthesia, you can just lift it and cut it. And if it is a large one, you can put a small amniotic membrane. Or if it is a small one, you can just cut it and leave it. This will work. See, this is a large one, so I placed an amniotic membrane over there. This would definitely reduce the symptoms of the patients. And pterygium is also one of the causes if you operate only the cataract and leaving behind the pterygium, because of the presence of pterygium, there will be worsening of the ocular inflammation that will lead to dry eye. It can be treated with topical steroids and lubricants. And concretions that we sometimes miss, and that you have to lift the upper lid and see if there are any concretions, remove them, and you can add them with the teardrops. Watering following cataracts is common because we give nowadays we give a lot of medications following cataracts. That medication itself can cause the punctum stenosis. Treatment includes a course of steroids and punctum dilatation. This you can do in your OPD, or if it is a very small punctum, you can put a perforated plugs or like mini Monaca. Thank you.